On December 20th, 2022, was my big knee surgery. I had knee surgery in December 2022 and got a total prosthesis.
It was obvious to me and my colleagues that Mr. Seel's mobility had simply decreased rapidly over the past year. The encounter with Dr. Kremer at the DKOU was fortunate and led to mutual trust, which then also made Mr. Seel a patient of Dr. Kremer.
My name is Kremer. I'm the medical director of the Athos Clinic in Frankfurt and chief physician of endoprosthetics there. And that's what I do every day. Endoprosthetics, knee and hip, that's my daily business. The Seel case was a bit special in the respect that he had received a Gore-Tex ACL replacement almost 30 years ago and a post-traumatic arthrosis with a pronounced instability of the knee joint, and a large bony defect had developed.
It was already clear from his pre-operative pictures that bone was lying on bone here. The arthrosis in the knee had already reached a very advanced stage.
Of course, you are nervous before such an operation. But Dr. Kremer and his team alleviated my fears. It wasn't all half as bad as one thinks.
I often plan in the presence of the patients. If you can simply show them, look, I tilt the implant a little like so and then place it during surgery like this. Of course, this creates a degree of confidence that you have dealt intensively with the individual case and do not just operate by default. So, the 3D hybrid planning for Mr. Seel done together with the mediCAD experts was of course great for me. I have there someone who is proficient in the program to whom I can express my wishes. So, turn the femur 3 degrees inwards again or move the tibial plateau here or there. It's a complex system with a multitude of possibilities, and naturally you must have experience.
It is particularly important to us at mediCAD that doctors learn to master our software as quickly and effectively as possible. The learning curve of the 3D planning is certainly steeper than the one of the 2D planning, but once you have climbed it, 3D planning is almost as fast as 2D planning.
Especially with regard to the newer philosophies with kinematic alignment, mediCAD 3D offers more options to position the prosthesis and to see how the bony coverage is, how the orientation of the prosthesis is, as well as how my cover is, especially with such a large bony defect, whether I run into any problems with the positioning of the implant.
Of course, Dr. Kremer could have planned simply and quickly in 2D, but for the sizing and rotational alignments of the axial plane, a knee CT simply provides much better insights, and you can estimate the surgical result much more clearly.
The more complex the systems are, the better trained you have to be, and you can do a lot with this mediCAD 3D planning. You have to be trained to take advantage of the possibilities, and for that you need someone to show you how it works. I think most endoprosthetics are now totally versed in 2D planning. We have been doing this for many years. We have also gone along with the development steps at mediCAD, but this is something new. And of course we have to learn it in order to be able to use it optimally. As expected, Mr. Seel's surgery went well. The problem we had was the Gore-Tex tape. We already knew that before. We had already seen how big the defect was. Removing these Gore-Tex fibers from the drill channels is normally extremely tedious, and as it was in this case as well. Once this had been done, the implementation of the prosthesis was ultimately completely problem-free.
I should have done the operation years earlier, so I would have restored my quality of life even faster. I did rehabilitation in Bad Homburg at Maintain. Great people with expertise who have fully restored me. I am now back to doing sports again and feel good.